Now I am going to invite Dr. Satyajit Sinha, who will be actually covering for Dr. BIBHUTI Prassan Sinha, who could not make it. He would be talking on Phaco in post in trabeculectomy eyes. You all know he's a very popular person. He is a member ARC East Zone and chairman scientific committee of Bihar Ophthalmological Society also. So he's going to talk on this important topic.
I'd like to thank Dr. Subhash Prasad sir for giving me this opportunity. And most of all, I should thank first all of you. Food is right there. It's lunchtime. And your dedication and absolute commitment to good ophthalmology is holding you here. So thank you for bearing with us during this lunchtime. Today I'll be talking about phacoemulsification in patients who have already undergone trabeculectomy. And remember, these are patients who have already compromised vision. They have an expectation, no matter how much you tell them, they have an expectation that one day when my cataract surgery is done, my vision will absolutely become all right and I'll be fine. And we are not able to reach that expectation, and that is where everything falls apart. We want to make sure that we don't make things matter worse by some complication in the surgery, so on and so forth. So what are the pitfalls in this? One, it's a challenging proposition for any surgeon, because whatever little vision is remaining, you don't want that patient to be devoid of that. Glaucoma requires... Glaucoma requires lifelong management. The development of cataract is a significant concern because its treatment may lead to loss of intraocular pressure. The visual field is also an issue when there is advanced cataract, and most bleb failure occurs soon after cataract surgery. Now, trabeculectomy significantly increases the risk of cataract formation. This has been taught to us for many years now. Major risk factors for cataract formation are complicated post-operative course following the filtering procedure, flat anterior chamber, post-operative inflammation. And as we all know, one study says that there's an increased risk of cataract formation by 14% post-trabeculectomy. So what are the confounding factors? Low corneal endothelial count, poor pupillary dilatation, atrophy and floppy iris, shallow AC, hypotony, pre-existing zonular weakness, extra caution to prevent posterior capsule rupture and vitreous loss, post-operative uveitis, post-operative bleb failure, and post-operative enhanced need for anti-glaucoma medication. So all those things contribute. There are several factors associated which leads to increased risk of loss of IOP, which are eyes with high IOP, younger patients, intraoperative iris manipulation, early IOP spike of more than 25 millimeter of mercury, posterior capsule rupture with vitreous loss, which is one thing we have to take care that it doesn't happen, otherwise it makes things even more worse. Interval between trabeculectomy and cataract surgery of less than 6 months. And through the presentation, I'll show you of how studies have shown that the gap should be there of more than 3 to 6 months. Now, pre-operatively, it is very important when you are taking up these patients to evaluate the bleb function. From before, you have to do proper IOP measurement. A good gonioscopy is very important, and you have to be very careful when you're doing gonioscopy in patients who have a bleb. Extent of the optic nerve damage and corneal endothelial cell count with specular biomicroscopy is very, very important because there may be compromised endothelial cell count. Corneal topography is very important. Assessment of pupillary dilatation is important. Evaluation of the type of cataract and lens density is important. In eyes with advanced cataract where fundus evaluation and fields are not possible, in these patients, B scan is very important to rule out gross retinal abnormalities such as RD, so on and so forth. Rule out zonular weakness and pseudoexfoliation. In preparation for these patients, intraoperative measures for preparation, ideally topical anesthesia if you could do, but if you are not confident, go ahead and give a block, and there's no need to be bringing anything in between and doing a topical. You can give block and do it, but make sure that you're not giving a retrobulbar anesthesia. Incision, clear corneal incision should be away from the side of trabeculectomy. Paracentesis port has to be away from the bleb. To counter pupillary meiosis, injection of high molecular weight viscoelastic or stripping of the pupillary membrane may be performed when required. Dye during the capsulorhexis if you require, depending upon the grade of the nucleus and the red glow. The staining of conjunctiva overlying bleb through sclerostomy ostium intraoperatively assessment of the bleb function is important. It helps in making the rhexis. Irrigating fluid, chilled BSS plus used will help to protect the endothelium also. When you're doing the hydroid dissection in these cases, in a compromised corneal endothelium should be protected by high molecular viscoelastics. Nuclear management, if there's a shallow anterior chamber, so the height of infusion bottle should be increased. Vacuum settings should be kept on the lower side in these patients. Phaco emulsification should be performed in the capsular bag to as far as possible, and use standard stop and chop or phaco chop nucleotomy methods. Cortical aspiration through the cortical cleanup to avoid inflammation, thorough cortical cleanup to avoid inflammation resulting in bleb failure at a later date. When you're inserting the IUL also, you have to be very careful that it's in the bag. Square edge, single piece, foldable hydroacrylic intraocular IUL is best. Monofocal aspheric IULs have gained popularity. In case of a PCR, sulcus fixation of multi-piece hydrophobic acrylic IUL can be done. A thorough viscoelastic removal is mandatory. Bleb function must be assessed by injecting BSS, which we all do at the end of trabeculectomy. An internal revision of the performed by passing a cyclodialysis spatula through the wound or paracentesis port to the sclerotomy fistula and then to the subtenon space. Gentle arcuate movements under the scleral flap may re-establish bleb function. Suture applied to watertight closure of phacoemulsification incision if you are not very confident that the wound has closed properly. Subconjunctival injection of 5-FU may be given, or mitomycin C may be given if there is a chance of bleb failure. Now this is a video, as all the speakers have acknowledged,
of glaucoma with advanced
video of being
and
from Dr. Subhash Prasad. I also do the same.
Attention.
And in this we will be seeing the phaco surgery
to the functioning blade, to prevent damage to already compromised ganglion cell, and to prevent late bleb scarring. High intraocular pressure during the surgery can actually damage the remaining ganglion cell, ultimately leading to the
pictorial representation.
And not only that, the increased hydrostatic pressure,
so as we said earlier, you have to keep the parameters low,
the bleb to give away and cause bursting of the bleb, leading to bleb leak. Presenting a video of
this is a case of a 65-year-old gentleman
case of glaucoma
who had open-angle glaucoma and who had trabeculectomy 4 years back.
Nuclear sclerosis.
You can see there's a grade 4 cataract. The bleb is
disc,
well
OCT
formed.
and perimeter.
This is the picture of the optic nerve head, and this is the picture of the OCT and RNFL.
One can damage the bleb during the insertion.
Even when you are putting the speculum, you have to be very, very careful that you do not hurt the bleb. This is one of the things you must do yourself. Otherwise, in all routine cases,
just to demonstrate that the bleb is not leaking at this point of time,
make the next case ready for you. But in the patients who have had trab, make sure that you are putting the speculum yourself.
And one main port,
this is the fetal test which is being done to make sure that the
I'm going to do
bleb is not leaking.
Jepto-assisted capsulorhexis in this patient. Before that, I formed the chamber with good quality viscoelastic.
And
after suction, energy is delivered to get
you could go ahead and make your own rhexis with a routine cystotome also.
And once it is made,
this is not an absolute requirement.
Drawn from the anterior chamber. Hydrodissection is being done here.
You have to be very careful when you are doing the hydrodissection,
and
you have to make sure that the nucleus is rotating before you start the phacoemulsification surgery.
One has to keep the bottle height so high that
now the bottle height versus IOP in this
may rise up to 75 mm mercury. But here I will do the phacoemulsification using the active fluidics of
the surgery has been initiated,
which can be done even with the pressure of 30 mm of mercury, which is very safe in this type of patient. And with this
Now
much of
see,
the
you
pressure,
have
the
to be
chamber is
very
very
careful.
stable
Whatever
and I am
Phaco is
able
happening,
to
that everybody
crack
is
the nucleus in two halves
acquainted with. But
and then
see
we'll
the
rotate
distance from the
and
bleb of the
make it complete
paracentesis and
two halves
of
so
the
that
main incision. That
further
is what is
chopping is
most
made
important to
easier.
see in this.
And once
Otherwise,
the
we are all
nuclear
doing
pieces
Phaco
are chopped in
emulsification.
multiple pieces,
So you have to be
it will
away from the
consumed
bleb so
one
that
by
you
one.
don't hurt
This
the bleb
intraocular pressure
at
of
any
30
point of
millimeter
time.
mercury is equivalent to the bottle height of 43 centimeters.
Is there a way to move this forward? No. Okay.
It is always advisable to inject viscoelastic through the site. It is mandatory to remove every bit of
As I
cortex
said, it's
so
very
that
important
there is
to
no
clean
chance
the
of any
cortical
inflammation
matter.
later on,
Because if there is any
which is so
remnant cortical
essential
matter,
to prevent
there will be
early
a
bleb scarring.
reaction, increase in
Inadequate
IOP,
removal of
so forth,
cortex
and make things
can
more
cause
complicated.
rise in intraocular pressure also. That there are less chances of wound leak once I remove the irrigation.
Even when you are putting these
aspiration
intraocular lenses, you have to be very careful.
I am trying
As
to
Dr.
remove
Subhash was saying, that
all
you should
the
not tear the posterior
viscoelastic
capsule.
from the anterior chamber
Any
and will
complication
do so
in a
behind the lens
patient who has
also
undergone
because
trap
retained viscoelastics are
will
known to
cause
cause
a lot of
early rise in
disasters. So you have
intraocular
to
pressure,
make sure
which is
that
again detrimental to
absolutely a
these
perfect
compromised
surgery is
optic
done
nerve
and no
and
viscoelastic
can
should
also
be left
cause
behind the IOL as we
inflammation
do
or
routinely
increase
in
in
all the cases,
inflammation,
but
which
in
is
this
again
case,
not
we have to
required
make sure
for
that no
bleb safety.
viscoelastic is left
Checking
even a
again the
little
bleb
bit. And
function,
once
whether
again,
it
it's
is leaking or
important
not.
to do
You
this
can
little
see
test
that
to
with
see
cedar test
that the bleb
it is not leaking. That means the bleb
and
has
that
not
your
been
surgery is
injured.
successful. Now, post-operative considerations, you have to do a close monitoring of this patient. You have to monitor the IOP spikes and visual fields. You have to watch out for early signs of bleb failure. And if that is happening, you have to take the help of 5-FU and mitomycin C. You have to vigorously use topical steroids to overcome inflammation. Early detection of corkscrew vessels and encapsulation are signs of imminent scar formation, and subconjunctival 5-FU can be given in such cases. Now, I was saying, if you see in this study, in the second column, you can see the time between the trab and cataract surgery, the months. So when the time period is more than 3 months, the success rate is the highest of being 86%. So you should give this time more. The time between the trab and the cataract surgery that you're doing should be more than 3 months. So the last slide, delay the pearls which you have to remember. Take-home messages are: you should delay the cataract surgery until the bleb has matured, at least for 6 months. Assess the bleb function before surgery. Evaluate pupillary dilatation. Minimize conjunctival trauma. Utilize a small clear corneal incision as far from the bleb. Assess bleb function upon completion of cataract surgery and revise if needed. And aggressively treat post-operative inflammation and IOP spikes. Thank you so much for your patient hearing.
Thank you, Dr. Satyajit.